Hello and welcome. My name is Joe Caramelli, and I oversee Grand Rounds for the Department of Psychiatry and Behavioral Sciences. And for this year's Grand Rounds series, trying to include presentations focusing on a theme called Next Steps in Care. And today we're here about training, workforce, and more in geriatric psychiatry related to next steps in care and that subspecialty and part of psychiatry. There's a core group of us who work on Grand Rounds each week, including Samhara Braha doing coordination and communication, and Mike Walker on technology. And thank you, Brandon, for being here today on the technology. We archive our presentations on the Grand Rounds website, and you can view presentations from all year. I want to acknowledge funding for the Grand Rounds series from the Ripley Fund and from the Garvey Institute for Brain Health Solutions, which is also funding today's presentation. Comments and feedback, you can fill out the Grand Rounds speaker evaluation at the end of the presentation. I'll put it in the chat box close to the end of Dr. Wong's presentation, or you can always write to me with any comments. And now a little bit about today's presenter, a local presenter, Dr. Lucy Wong. Dr. Wong is currently an assistant professor in the Department of Psychiatry and Behavioral Sciences here at UW. Some background on Dr. Wong. Now, Dr. Wong completed psychiatry residency, followed by fellowship training in geriatric psychiatry here at UW. After that, Dr. Wong completed research fellowship training in a MyRec-based fellowship at the VA Puget Sound, focusing on neuroadrenergic system, neuropsychopharmacology, and disturbances in dementia. Dr. Wong then accepted a faculty position, which was initially on a VA Career Development Award, which again continued work on adrenergic system in individuals with Alzheimer's and dementia. Stayed on at UW, has worked at the VA, and has since become Fellowship Director of the Geriatric Psychiatry Fellowship. And as a geriatric psychiatrist, Dr. Wong's professional interests revolve around improving quality of lives for people with dementia, dementia-related psychiatric symptoms, and their caregivers. And Dr. Wong provides direct clinical care as a psychiatrist at the VA Puget Sound and is involved in projects addressing dementia-related agitation. I'll stop there for now and turn it over to Dr. Wong.
Thank you so much. I'm now sharing my screen. Feel free to let me know if it's not working. Again, thank you again for this opportunity to speak towards a topic that is close to my heart as the Geriatric Psychiatry Fellowship Director here at the University of Washington, which is the state of our geriatric mental health workforce and what I see as a growing need, and maybe me using this chance to talk as an opportunity to raise some red flags, considering this growing need and my concern that our workforce needs some help. So let me tell you more about why this is and where I'm going to go with this. I'm going to divide this presentation into 3 parts. One is to introduce who the geriatric mental health workforce is. I'll confess, I actually had a discussion with a medical student once who told me she had never heard of geriatric psychiatry, didn't even know what we did or that we existed. I'll talk in the middle section about those concerning trends that I just sort of hinted at, and then finally some ideas about how we can help as we, realize that we might not have a workforce that meets the need, and how do we kind of leverage our expertise or support public health initiatives that will help us meet that need as it grows. So the first section, who are the geriatric mental health workforce? Who we are, what do we do, and why might we possibly be helpful or important? I'd like to start with a bit of a thought exercise with you. I'd like to think about your patients and think about what are some gaps you have noticed when working with your older adult patients. Perhaps, unless you're specifically only working with children and adolescents, you are probably working with older adults. So perhaps you are providing psychotherapy and you're beginning to suspect that your patient is developing mild degrees of cognitive impairment. What do you do in that situation? How do you refer them for evaluation? How do you decide to modify your psychotherapy in light of mild cognitive impairment? Or how do you decide when psychotherapy is no longer effective because of progressing cognitive impairment? Or perhaps you are doing a suicide risk assessment and you are working with an older adult who's socially isolated, widowed, maybe has a poor perception of their health, has multiple medical conditions, they may tell you that their spouse has passed away, their friends and family have passed away. They're not afraid of death. They're concerned that their lung or their heart condition will get worse, they'll become disabled, and they tell you, I will take my own life when that disability happens because I don't want to be a burden on society or on others. So what do you do with that kind of risk assessment? I can provide a kind of a personal example. I worked with a patient at one point with Parkinson's disease dementia. And before he was referred to me, he was actually in an acute crisis situation. He was having hallucinations, he was having agitated behaviors, impulsive behaviors, including self-harm behaviors. His wife brought him to a local emergency room in a rural area in Washington and was actually told that they couldn't take care of that patient. Presumably that facility called other facilities, and those other facilities likewise said either they were full or they did not have the expertise, the setting, or the skill sets or staffing to be able to provide care to that patient. So that patient was actually discharged to home, even though they were experiencing significant psychotic symptoms and had engaged in self-harm behaviors. So you think about some of these sort of knowledge gaps that you may or may not have, and for me, sort of these systems gaps. For that particular patient of mine, what was it that delayed referral to me until after a crisis situation? What was it about their care in the months leading up to that crisis situation that perhaps detection or prevention options were missed, or opportunities were missed? And what was it about systems where entire groups of hospital systems were telling this patient, we don't have what it takes to take care of you? So the reason I point out these gaps is that geriatric mental health specialists can advise, consult, and actually fill some of these gaps. This is what we do and why we're important. So I'm going to now take this next group of slides to introduce who some of us are. And I represent geriatric psychiatry, so I'm going to tell you about who we are. What is geriatric psychiatry? Geriatric psychiatry is a branch of medicine and a subspecialty of psychiatry dealing with the study, prevention, and treatment of mental health disorders in older adults. The first certification examination in geriatric psychiatry was administered by the ABPN in 1991, so we've been around for a while. And since then, as of 2021, according to the ABPN website, there have been 3,638 initial certifications. So over 3,600 of us have been board certified geriatric psychiatrists nationwide since the start of this subspecialty being around. In terms of how we're doing, in terms of a pipeline for this, for us as a workforce, we are having some challenges, and I did want to highlight that to you. This is pulled from the APA Residence Census published in 2019, and what it is a summary of psychiatry fellows in subspecialties from 2012 to 2017. On the left side, I'm going to just mainly focus you on that table. You have the year 2012 to 2017. Let's take a look at addictions. That's that first column. The addiction psychiatry fellows filled 67 spots. There were 67 fellows in their program in 2012. And in 2017, there were 74. So you think, wow, there are only 74 addiction psychiatrists graduating nationwide in 2017. That's not nearly enough. Let's look at child and adolescent. 2012 or 855, moving down to the bottom of the table, 2017, 865. Child and adolescent fellowships are 2 years, so per class, it's more like 450, half that number. So 450 child and adolescent psychiatrists graduating in 2017. Not nearly enough for the number of patients needing a child and adolescent psychiatrist. I'm going to skip ahead to geriatrics. 2012, we had 67 fellows. In 2017, that went down to 53. And the last row of that table indicates the total growth from 2012 to 2017. Geriatric psychiatry, we were the only one that had negative growth. We went down 21%. So let's just think about this. Nationwide in 2017, we graduated 53 geriatric psychiatrists total, nationwide. Here's also another slide drawn from the APA Residence Census, which tells you about our fill rates. So the top table is 2017, the bottom table is 2018. Again, I'll start with addiction psychiatry because they're on top. If you look at the 2017 table, they had 83 spots filled, total filled complement. Next column was total approved complement, means they had 129 spots available. The percent filled was 64%. Child and adolescent, they filled at a rate of 79.8%. So you look at the last row in that top table, geriatric psychiatry, we had 59 filled. We have 155 spots open. We can train 150 geriatric psychiatrists per year in the US. Our percent fill rate was 38%. 2018, looking at that bottom row, didn't really improve. We got a 35% fill rate. So I am essentially highlighting the fact that geriatric psychiatry is important, but we're not producing the number of geriatric psychiatrists that many people think we are. How do we compare to some of our colleagues? Geriatric medicine, and many of you have heard of geriatricians. They're the branch of medicine concerned with the diagnosis, treatment, and prevention of disease in older people and the problems specific to aging. So they are the primary care providers for older adults. This was pulled from the NRMP match data report from 2021. In 2017, that blue bar, there were 401 positions offered. The green bar was positions filled. So there were 179 filled versus the red bar, 222 unfilled. Move over to 2021, 400 positions offered, 208 positions filled, 192 positions unfilled. So about 50% fill rate for geriatric medicine, our geriatric primary care colleagues. So again, they are doing a little better than geriatric psychiatry, but again, not nearly enough, and plenty of opportunity for more people who trained in this subspecialty. Along with my theme to start introducing to other colleagues who are in geriatric mental health, I do want to highlight my geropsychology colleagues. This is a field, so this is defined from the APA website, the field within psychology that applies knowledge and methods of psychology to understanding and helping older persons and their families maintain well-being, overcome problems, and achieve maximum potential during later life. I feel like it's a tremendous mission statement for geropsychology. It became a specialty in 2010, so they're relatively young subspecialty. In 2014, the American Board of Professional Psychology added geropsychology as a boarded specialty. I don't have exact numbers for the number of geropsychologists. I did happen to look at the American Board of Professional Psychology's website and try to do a provider search. And I was able to find less than 100 board certified geropsychologists on their provider search engine. So chances are there's still relatively few geropsychologists, at least the board certified ones, maybe about less than 100 nationwide. So I happen to work with 3 of them. So after doing this exercise, I discovered I am a very lucky person to have interactions with at least 3 geropsychologists. I'll finally take a couple slides again, just to highlight different professions and what ones may or may not have special certifications in geriatrics. Advanced practice RNs. In 2013, the certification for gerontology for nurse practitioners was actually phased out and combined with adult care certifications. I'm not sure what to make of that. It does probably mean that all nurse practitioners who pursue an adult care certification got a probably extra or a lot of gerontology sort of phased into their curriculum, but they no longer have a specific certification for gerontology. Physician's assistants, the best I can find, no added qualifications in geriatrics, but geriatrics residencies do exist for those who are interested. For RNs, registered nurses, there is a certification in gerontology. The American Nurses Credentialing Center does offer this certification. And board certified geriatric psychiatrists also exist as well. They have residency programs and a certification process. My social work colleagues are highly valuable. Social work, so the National Association of Social Workers does offer credentials in gerontology, and they offer 3. There's the social worker in gerontology, which I believe is a bachelor's level, and the clinical social worker in gerontology and advanced social worker in gerontology, which I believe are master's level certifications. Finally, there are also board certified clinical specialists in geriatric physical therapy and gerontology certified occupational therapists as well. Finally, and maybe most importantly, I want to highlight direct care workers as a very key part of geriatric workforce, or the geriatric workforce, or even the geriatric mental health workforce. These are our nursing assistants, home health aides, home care aides, personal care attendants. These are the workers who do the day-to-day, everyday hands-on care. The challenge is that they may have variability in training. Some don't receive dementia care training in particular. Turnover rates tend to be high. Compensation is low. Their work environments are really challenging. So they are particularly vulnerable to instability in their workforce. And I'm going to highlight in a little bit about how that's being exposed in light of COVID. All right, so I've just summarized who we are, and I'm going to actually use this next session to highlight some concerning trends. So let's go ahead and look at some statistics. So this was produced by the United States Census Bureau based on 2017 projections. The headline for this is, for the first time in US history, older adults are projected to outnumber children by 2035. For the first time. 2035, there will be 78 million people over the age of 65 compared to 76.4 million. So that's that little middle bar in on the bottom there. This is fueled by the growing number of baby boomers who are going to progress to that 65 plus age over time, and a declining sort of birth rate, I guess, reducing in lower numbers of children. So the need for providers for older adults are growing. I found an interesting report. This is from the Commonwealth Fund. The title of the report is Comparing Older Adults' Mental Health Needs and Access to Treatment in the US and Other High-Income Countries. So what this was is a summary of the 2021 Commonwealth Fund International Health Policy Survey of older adults. This is a survey that included more than 18,000 adults aged 65 and older in 11 high-income countries. One of the findings of this report, or reported in this report, is that 1 in 5 US older adults have a mental health diagnosis, so 20%. And actually this is consistent across other studies that I've looked at as well. Now, these researchers fortunately have found, the survey mentioned that the US older adults did seek after and did receive mental health care more than other countries, other high-income countries. So that was reassuring. I am going to highlight a little bit of a teaser here. It's not necessarily the main part of my talk, but this concern about Medicare, that 26% of US older adults said they had limited access to mental health care because of cost. So that will be a challenge for many as more and more people, as they're older adults, rely on Medicare and some of the limitations that Medicare has with regards to access to mental health care and sort of reimbursement or financial sort of support for mental health care. Okay, so assuming that we have 70 plus million older adults and 20% of them are going to have a mental health diagnosis, how many geriatric psychiatrists do we need? I pulled this from the AAGP website. They had a copy of the Institute of Medicine study on mental health workforce of older adults fact sheet. And their calculations were assuming 80 new geriatric psychiatrists per year, which you actually know is a poor estimation. It's more like 50 or 60. But assuming 80 new geriatric psychiatrists per year with a 3% attrition rate, there's going to be approximately 2,640 geriatric psychiatrists for the year 2030, which is only 8 years from now. But they estimate the need is twice that much. They estimate the need is 4,000 to 5,000 practicing geriatric psychiatrists. In addition to the practicing psychiatrists, they estimated 1,220 physician faculty and 919 non-physician faculty needed for education to maintain the pipeline of geriatric psychiatrists. Now, you could argue that perhaps the AAGP and the Institute of Medicine are being a little alarmist. Not every older adult with a mental health diagnosis absolutely needs to have a geriatric psychiatrist. A lot of mental health conditions are appropriately and adequately treated by primary care, or could of course be treated by any general adult psychiatry colleague of mine. So I wanted to argue that perhaps there are some diagnoses for which geriatric psychiatrists pretty much are the only ones who are uniquely qualified to treat, and that is patients with cognitive impairment. I have consistently experienced personally that my colleagues around me, when their patients develop cognitive impairment, they get a little bit, they ask for my help. So let me talk about Alzheimer's dementia. So this graph is pulled from the Alzheimer's Association's annual facts and figures, something that is very important and I encourage people to keep an eye on it if they're interested in this field. It's a really high quality summary of where Alzheimer's dementia is going. But this particular graph is a depiction of the projected number of people aged 65 and older in the US with Alzheimer's dementia from 2020 to 2060. So in 2020, which is essentially now, there's an estimate of 6.1 million people in the United States with Alzheimer's dementia. And let's pick a middle range. Let's pick 2040, the one in the middle. There will be 11.2 million people with Alzheimer's dementia projected. So that's almost double. So for those of you who do happen to have patients with dementia in your practice, some of my acute care colleagues, I think you're sensitive to this. Think about the number of patients that you have and that they're going to be twice as many in 20 years, which is within the career range for many of you in the audience, I would presume. It's a lot. In this slide, I did want to include just to highlight, it's a little bit of a tangent, but it's a highlight that mental health and specifically dementia care needs may vary across race or ethnicity based on differing rates and diagnoses along these lines, as well as other factors. So it highlights the importance not only of good dementia care, but also sort of the culturally sensitive nature of dementia care that may be needed. This is a graph that was pulled out of a study examining electronic medical records of members of a large health plan in California that indicated dementia incidence. And they found that the highest incidence rate was for African Americans, which is the purple line, with intermediate, those who identified as Latino or Hispanic, so sort of those middle, like the little gray line, and also white, so sort of that pinkish line, and the lowest, which is that darker line for Asian Americans. This is not inconsistent with other studies. There's another study based out of Chicago, which was more of a prevalence study indicating that 16.8% of Blacks in that study versus 14% of those Hispanics versus 10% of those who are white were diagnosed with dementia. So this higher risk is thought to be due to the discrepancy or disproportionate degree of risk factors that might tie along with race or ethnicity. There's some variations in medical conditions, health-related behaviors, and socioeconomic risk factors. So this means that Alzheimer's dementia prevention efforts, treatment, and caregiving support really should be addressed in a culturally sensitive manner. So this complicates sort of the workforce issue, but I wanted to highlight that for your reference. Okay, back to my argument before. So I argued earlier that the number of people with Alzheimer's dementia is growing, and that 20%, I'm sorry, I forgot to mention 60%, I'll mention this now, 60% are gonna have a complication, specifically agitation or aggression associated with it. So I include this slide to remind people that people with dementia have a globally brain damaging disease. So any type of mental health or behavioral psychological symptom can pop up. And this is actually just a summary of the 12 items on this neuropsychiatric inventory. It's a scale that's used in research to rate the degree of behavioral and psychological symptoms that people may have in dementia. And they really run the gamut. Delusions, hallucinations, agitation, aggression is the one that's particularly problematic, I think. But depression, skipping on to the second column, nighttime behaviors, motor disturbance, irritability. These are symptoms that impair quality of lives, not just for patients with dementia, but also their caregivers. Most, if not all, so 97% is the number I've seen of people with dementia will experience one of these in their lifetime or during the course of the disease. And as I just mentioned earlier, 60% with agitation and aggression in one sample that I looked at. It actually varies. It's a higher number of people in long-term care settings and maybe a little bit lower in community settings. But for the sake of this argument, I'm going to pick 60%. Here's a napkin calculation here, let's say 2030, based on that graph from the Alzheimer's Association. We have 8.5 million people with Alzheimer's dementia in 2030. And we estimate 60% will have agitation at the time. That's the prevalence rate, 5.1 million. If, according to an Institute of Medicine fact sheet that I provide, I talked about, a few slides ago, there are approximately 2,640 geriatric psychiatrists in 2030. That results in one geriatric psychiatrist for every 2,000 patients with a specific diagnosis, agitation and aggression related to dementia. And I'm picking this because it's one of those conditions that most of my non-geriatric colleagues find difficult or are uncomfortable with, and for which a geriatric psychiatrist could be, particularly attuned towards treatment, being the treatment provider for that. You can think about my patient, that example I gave earlier, my Parkinson's disease patient who went to the ER because of agitation, self-harm behaviors, and hallucinations. And entire healthcare systems I mentioned said, we can't treat you. So this is something that is unique, I think, to us. And I'm highlighting the fact that there aren't enough of us to be able to provide that treatment, even for that small specific population. I'm going to shift over and talk about direct care workers as a second example of a mental health, geriatric mental health workforce need, primarily because I've just been inundated by these news reports about our long-term care facilities being understaffed, and highlighting, or maybe how COVID-19 has exposed the vulnerability of this particular workforce. So I found this literally this morning. I just threw this in last minute. This is from the website, from King Fai's website. And the headline is, "Every bed is full. UW Medicine warns hospitals still at capacity despite falling COVID cases." Dr. John Lynch with Harborview Medical Center is reminding everyone that hospitals are still feeling extreme burden created by the pandemic. While mask mandates and COVID vaccine requirements are seemingly being dropped left and right, the UW Medicine hospital system is warning that capacity remains virtually maxed out across all 4 of its campuses. This article goes on to explain that, the past few months, hospitals, including University of Washington, have been dealing with a backlog of patients who are stuck in the hospital with nowhere else to go because of staff shortages at long-term care facilities. This article goes on to quote spokeswoman Susan Gregg. She says, UW Medicine has roughly 215 patients that are pending discharge to other facilities. 215 patients in UW system don't need to be in a hospital, but they can't move to a long-term care facility because of long-term care facility bed capacity and staffing problems. This is another headline I found last week. This is Seattle Times. Washington long-term care facilities to free up hospital beds with new non-COVID units. In an effort to ease Omicron strain on Washington hospitals, 10 long-term care facilities statewide will open new units to treat non-COVID-19 patients who no longer need acute care. So this article describes how the Washington Department of Social and Health Services, or DSHS, has contracted with a temporary nurse agency to hire 250 nursing professionals for long-term care beds. According to, further on in this article, the article, or the reporter, describes how long-term care facilities have faced staffing challenges, limiting the number of non-COVID patients the facilities have been able to admit. And hopefully this, this bolus of funding to hire these temporary nurses will free up, reopen some of these long-term care beds so that hospitals can be able to discharge some of their patients. This article also quotes Washington State Hospital Association Vice President Taya Briley, and she says, hospital leaders strongly support the state's plan to free up acute care resources and beds. And she goes on to say, quote, "We also urge the state legislature to take action and provide increased funding for nursing homes. More enough funding for nursing homes," she adds, "would keep the services open and remove administrative process barriers to discharging patients from hospitals to long-term care centers." So I don't personally work in the acute care setting, but I suspect some of you who are know this firsthand, and sort of the challenges that we're dealing with because of staffing issues highlighted by COVID in our long-term care facilities, exposing a vulnerability that's sort of blocking, halting some important aspects of care. Okay. So what I've done so far is I've introduced who we are. I gave 2 examples: geriatric psychiatrists and our direct care workers as being, important, and not enough of us to meet demands in current or near future demands. So I'm going to close up our last section on, how do we help? How do we manage this? I'm going to start with a few slides on the pipeline. One of the reasons I suspect, and this is a belief of mine, that the pipeline may be lower than it needs to be is because of ageism. So what is ageism? Ageism is stereotyping of or discrimination against an individual group or group based on age. Now, sometimes it's not always, negative. It can be well-meaning, but sometimes in the end, it's still patronizing. It's still negative. One example is elder speak. So this is something that, we can try to address in our own habits, or if we see other people do. Elder speak, in case you don't know, is sort of that sort of tone of voice or terminology that we use with older adults that we may not use with younger adults, that infantilizes or patronizes them. So things like, oh, he's so cute, or he's curmudgeonly, or using overly simplified terms, or limiting the amount of detail that you provide in explanations based on an assumption you make purely by that person's age. Some real consequences of ageism. Ageism from, let's say, medical providers will cause providers more likely to view a negative outcome as a natural consequence of old age, therefore making them more pessimistic towards the outcome of interventions, perceiving more challenges to working with older adults, leading the provider to be less likely to intervene or suggest interventions in an older adult compared to a younger adult. I would potentially argue that the same could apply to an interest in going into a geriatrics focused field, that someone may be more pessimistic about the outcome of that type of care or that population, be less inclined to want to work with them because of perception that the outcome or the intervention will not work. And we all want to do work where we make a difference and we help people. But my worry is that with ageism, that is a false assumption that working with older adults is not helpful, or that they're too complicated or too challenging. In fact, I would say that one of the reasons I find greater satisfaction working with older adults is I do see the barriers, I do see the complexity, I do see how challenging sometimes finding a treatment that works, how that can be, but I see the intervention that I make still working and working well and working in the vast majority of my patients. And I find great satisfaction that I have helped overcome barriers that other people see as impossible to breach as ones that I can make a difference in someone's life. Okay, so still on the topic of ageism, what are some things that we can do individually? One is just changing our language. This is an easy one for all of us to do. I pulled this out from the APA Publication Manual's website. This particular sheet or page on the website recommends preferred language in publications. So publishing a paper, the problematic language that you want to avoid is the elderly, elders, elderly people, aged, aging dependents, seniors, senior citizens. So you'll see many of us getting away from using the term elderly. I still see it snuck into some publications and some talks, but many of us are instead using the term older adults, and that's what I encourage people to use. So preferred terminology: older adults, older people, persons 65 years and older, the older population. Down the bottom, avoid senility or senile. I would also avoid the term demented. Instead, use the word person with dementia or person with dementia use due to Alzheimer's disease. Just like we no longer say people are diabetic or schizophrenic. No, they're a person not defined by their disease. They're a person, an individual who has a disease. They have diabetes or they have schizophrenia. This is a patient with dementia. All right. Another thought exercise, again, along the lines of ageism, or sort of encouraging you to enrich your experience when you're working with older adults. So this thought exercise, what are some sociocultural changes that you can think of that occurred in the US in the past 100 years? Think about it, there have been a number of paradigm shifting events in the last 100 years. And the reason I'm asking you to think about this is the person that is in your room is an older adult. It's likely lived through some, if not most, of those events. And then they come in with a rich experience, a rich lived experience that I, as a younger person, couldn't even imagine. And that knowing what those experiences are, or at least providing some context, or keeping in mind that context, I'm sorry, allows me to come into the room with a touch of humility and a touch of respect for that lived experience that older adult patient of mine has had. I would like to acknowledge one of my geropsychology colleagues, Hallie Newsom. I borrowed this slide from her. This is sort of an idea of what some of those sociocultural events could have come up in your thought exercise. If you go back 100 years, women's right to vote, 1920, the Great Depression, World War II, Korean War, Vietnam War, the Cold War, cultural revolutions, so sexual revolution, Civil Rights Act, Stonewall Riot, Don't Ask, Don't Tell, gay marriage, technology, personal computers, internet, and then more recently in 9/11 attacks, 2001, and the #MeToo movement. These are all major paradigm shifting events in the United States. And again, reiterating, older adults have lived experience in all of these. More again, than someone younger like myself could imagine. And I want to bring myself into that room with the appropriate amount of respect and acknowledgement of that. Okay, I am off my soapbox about ageism, and I do want to now speak specifically about some pipeline issues. I want to highlight a study that was published last year that directly talks about the pipeline for geriatric psychiatry, particularly in geriatric psychiatry fellowships. This study was a survey of general adult psychiatry program directors, and the aim of the study was to identify factors that may influence residents to pursue geriatric psychiatry subspecialty training. 24% response rate, I mean, it's a survey of busy people in the middle of COVID. Anyway, based on the results, they were able to determine that there was one independent variable that was associated with percent of residents that became geriatric psychiatry fellows. And that one independent variable was the number of geriatric psychiatrists at the resident's home institution. So the thinking around this, the proposed sort of rationale is that geriatric psychiatry and geriatric psychiatry faculty in particular can act as ambassadors to promote geriatric psychiatry. We can serve as mentors to inspire residents. We provide, if there are enough of us, can provide enriched opportunities, either clinically or through journal clubs, case conferences, didactics. Many of us could also influence curriculum development and rotation planning. So this is sort of a bit of a call out to any of my geriatric psychiatry faculty colleagues who might be listening, to I guess bolster the fact that we can inspire and we can influence, and our presence does indeed make a difference in encouraging any say residents who have an affinity towards working with elders to kind of pursue that additional step in training. Okay. Now, I was highlighted to this study by another one of my geropsychology colleagues, Doug Lane. He's the geropsychology fellowship director based out of our American Lake VA. He highlighted to me this interesting study looking at the pipeline for medical providers who work with patients with dementia. And I found this worthwhile sharing. This was a qualitative study which involved interviews of 27 physicians and nurses, 2 years out of training, so just out of training. And they did these interviews, and they actually found several themes themes present in those who preferred working with patients with dementia, as in those who actually were interested in sort of a practice or clinical care environment that was mainly towards dementia patients. One of those things was rewards of making a difference. And I think this is what I mentioned earlier in sort of the ageism sort of talk or section. There's a sense that people who preferred working with dementia felt like they were making a difference, and that they felt like this difference was even more valuable or important because they didn't see barriers as things they couldn't overcome, that the more challenging cases actually brought about more professional satisfaction because they were able to make a substantial difference in a challenging situation. And interestingly, those providers who preferred not working with dementia actually cited the same thing, that they felt like there was fewer reward or less reward working with patients with dementia because they saw the barriers as ones that couldn't be overcome. So I found that interesting. Another theme for those who preferred working with dementia that was brought up was a different type of care, meaning a holistic type of care, that those providers who maybe were less sort of intervention or medically oriented, but more kind of a holistic, whole person oriented type of model of care, they tended to gravitate, or that was a theme that was present in their reasoning for preferring to work with dementia. And then there was sort of alignment with personal characteristics as well. So when I think about supporting the pipeline, I'm interested in maybe identifying trainees or anyone who kind of fit this profile, and also to encourage it if we can, in any way that we can. Okay. All right, so that was the pipeline. I'm going to devote one slide to leveraging expertise through innovative care and education models. So we could improve the pipeline, but probably will never get quite enough. So somehow we've got to leverage the expertise that we have to reach more people if we can. So I'm actually basically just using the slide to give shout outs to faculty who are directly affiliated with the Geriatric Psychiatry program, Geriatric Psychiatry Fellowship Program. I can't not speak about collaborative care. It is the behemoth in our department. And I want to remind everyone that our chair, Dr. Unan's early work in collaborative care was focused on geriatric mental health, was focused on late life depression. I also want to shout out Mark Snowden and his work in Pearls, at a program to encourage active, rewarding lives, which partners with outreach community workers to provide evidence-based care in the home for older adults with depression. Also shout out to my colleagues here at the VA with regards to telemental health, David Swong, Stephen Thielke, Gail Lee. I was even involved, and still am involved, in a telemental health project, providing good geriatric and psychiatry or mental health and also dementia care through telemental health technologies years and years before COVID. So we were one of the innovators and kind of more established programs providing telemental health to older adults. Also want to shout out, there's a Project Echo actually there were several Project Echoes in our institution, but one I'm going to mention right now is one based out of the geriatric medicine program, where so Project Echo, if you're not familiar, it's a model consultation and education model where usually it's a kind of a using telehealth or telecommunication technology, where large groups of people in a kind of large geographic area can call in. There's usually like a 15-minute didactic and followed by a case presentation, often a real clinical case by one of the participants in one of the outlying sites, and as expert panelist that does some exploration and teaching around that. And this particular Project Echo out of the geriatric medicine program, their participants are family practice sites around Pacific Northwest. And I wanted to highlight that Beth Lombardi, one of our geriatric psychiatrists, I think right now, Project Echo is going on right now, is one of those, is the geriatric psychiatry expert panelist on that particular Echo. Okay. I also wanted to devote a couple of slides towards another aspect of helping out the workforce, mental health, geriatric mental health workforce, which is supporting broader public health initiatives. I'm not going to go into these in detail. I list these for reference as publications of larger organizations, national think tanks on the mental health, and specifically geriatric mental health workforce, and really important work and smarter people than me, I think. So the Institute of Medicine in 2001, their publication, you can find it online. It's the Mental Health and Substance Use Workforce for Older Adults in Whose Hands? That's the title. SAMHSA, they have a document online, 2019, titled Older Adults Living with Serious Mental Illness, the State of the Behavioral Health Workforce. Now focused on dementia care, the Alzheimer's Association and Centers for Disease Control and Prevention. The title of one of their publications is State and Local Public Health Partnerships to Address Dementia, the 2018-2023 roadmap. So a very current and present roadmap to consider. I'm going to just take another moment to also talk about the 2016 Washington State Plan to address Alzheimer's disease and other dementias, because that is local and there is progress being made on that. So let me just give you this one slide here. So this was published in 2016. What the background is that in 2014, the Washington State Legislature passed a law to, the goal was to create a plan to address Alzheimer's disease. And so what this law did was appointed Alzheimer's disease working group, which included a number of private and public representatives, including several of our own dementia experts at the Alzheimer's Disease Research Center in the University of Washington. And they produced this state plan to address Alzheimer's disease and other dementias. So they proposed specific comprehensive, ideas about how to address these needs for Alzheimer's disease patients. So education, caregiver support, research, medical care, and others. And then they appointed a work group to take on this role, or take on the implementation of these items. And you can find their updates. They actually have an update, a 2021 update available if you wanted to find it. I picked out in the document a few items that specifically spoke toward the workforce issue. The first one is they actually have a section where they identify the importance of developing dementia-capable, culturally competent primary care workforce, I think recognizing that the bulk of this care will end up in the lap of primary care providers. So the specific items that they propose here are promoting the use of incentives, such as, but not limited to, loan forgiveness for clinicians going to geriatrics, also promoting the use of telehealth care, directly for individuals or as a supportive consultative model. And as an aside, in their progress report, they report another Project Echo Dementia based at the Alzheimer's disease, or a large part in the Alzheimer's disease research center. So my colleagues there are taking this on and doing a tremendous job. And this is a Project Echo, again, specifically for dementia care and providing consultation and education for primary care providers in the Pacific Northwest. The second item I was going to pick out in this Washington State Plan was to improve understanding of and response to challenging and/or complex behaviors. I'm looking forward to seeing what comes out of that. Their specific proposal was to create a network of trainers or resources to assist healthcare providers, specifically around challenging behaviors. And the third item was to strengthen numbers and effectiveness of long-term supports and services workers. So these are the direct care workers that I mentioned earlier. So they some of the proposals there were to enhance training, develop an enhanced training program specifically around caring for people with dementia. And in their updates, they were able to say that they did complete that program. They rolled it out in 2016, 2017. By offering a certification, they were able to elevate the status of this workforce. By offering that certification. They've also translated that training to, I think, 13 languages to ensure that the training is available to all workers in this category, and make this workforce trained and more effective, and have those resources accessible. All right, I think I am pretty much done. So let me just summarize all that information I just provided. You remember my three questions were, who are the geriatric mental health workforce? So the answer is the geriatric mental health workforce consists of providers from many disciplines. We are in a multi or interdisciplinary sort of group of people. The second was, what are some concerning trends? Using geriatric psychiatry and direct care workers examples, we can conclude the current workforce, unfortunately, is inadequate to meet a growing need. So how do we help? That was the third question. We can help by addressing ageism, elevating the field of geriatrics. Those of us who are geriatric specialists, we can leverage our expertise, and of course, supporting public health initiatives. So I want to say thank you so much for your time and for offering this opportunity to present something, like I said, that's close to my heart. I'm happy to answer or discuss any questions that you might have.
Okay, thank you, Dr. Wong, for walking us through this, for presenting on the workforce, key conditions in which geriatric psychiatry and related fields are especially appropriate to take on the care, and so on. I want to encourage any participants to write in with questions. We do have one question waiting for you, Dr. Wong. I'm wondering if you could comment on the work of neuropsychologists in the evaluation and care of individuals, older adults.
That was my fear, that I would forget someone super important, and that is the neuropsychologist. Absolutely. I consider neuropsychologists as one of my key partners. I think that there aren't enough of you. You're hard to find, just like all of us in geriatrics. And I wish that there were more of you, especially for those situations where I have patients where my dementia diagnostic sort of questions can't be easily answered without your expertise. So I think that maybe kind of the same concern. You're absolutely, yes, yes, I did. I shout outs to Emily Trichuk, Pamela Dean, who is actually moving on, I think, to the Cleveland Clinic, and certainly my colleagues at the Alzheimer's Disease Research Center. So thank you for pointing that out and that very glaring admission.
Now, other attendees, please write in with any questions you have, points about training, points about geriatric psychiatry in general. Now, as we wait for another question, I guess I'd like to pose something maybe too abstract, so answer it as you will. But I mean, do you see geriatrics in general, and I'm talking within medicine, as moving the way pediatrics is, where every discipline has more or less every discipline has a subspecialty that focuses just on that age group? Or do you see this mainly sticking within internal medicine and psychiatry? Focusing on older adult kind of subspecialties.
I think one of the challenges that we have is that everyone, no matter what field you're in, is eventually going to have to do some form of geriatric psychiatry. Like, you can be an ER physician, you can be a general surgeon, you're going to be faced with a geropsych issue. So I'm trying to think of how to answer that. It's one of those situations where if we can invest in and promote specialists, that will give us not just the direct, really nice expert care, but the consultants that we may need for all the other professionals who are going to need to. I mean, everyone is going to be working with the older adults, multiple adults, because of the way the demographics are changing by definition.
It is interesting, and I think you've proposed, if I've understood the examples you gave, proposed the subspecialist focusing maybe on key disorders, key clinical circumstances, rather than just the age being sufficient or to see a subspecialist, more so the clinical problem at hand.
Yeah, in an ideal world, I do feel like those of us who are drawn to geriatrics, sort of as subspecialists, we have a certain affinity. We will develop more experience and have maybe a slightly different skill set. And so I do suspect the type of care we give is at a, I guess at a different level, but realistically, there are not enough of us. And so to have a geriatric subspecialist for everyone, age 65, even though I would love that, I would want that, is logistically just pragmatically not possible. So and that's the case for psychiatry in general. Psychiatrists, there are just not enough of us. And so we need to leverage our expertise in some way to help our primary care colleagues who are probably doing the bulk of psychiatry at this point. So it's sort of the same question, just at a different scale. How do we, as geriatric psychiatrists, leverage our expertise, provide consultation, provide education and leadership?
A problem that we're all familiar with, amplified. Yeah. Now, a question came in on multiple medications, polypharmacy associated with cognitive decline. I wonder if you comment on that, the role of geriatric psychiatry with identifying usefulness of medications, knowing when it's appropriate to de-intensify, deprescribe. Yeah, deprescribing is one of those things that we do a lot. And I am
struck by and actually pleasantly surprised by the trainees that come through rotations here, how they sort of picked up on that and are working on that. Yeah, you know, it is very real that as people kind of progress in life, that somehow they get more medical conditions, they get more medications on board, or even for mental health conditions that they'll, you know, actually have higher, you know, doses or more psychiatric medications than they mentioned they eventually may need or not need. So what I tell trainees is that, you know, there are physiologic changes as people get older. So the doses that you give may not be the same dose as a younger person, that the dose that you give, that their blood level or the effective level in their system is higher than they actually need. So they actually may need lower doses as they move on. Also, older adults are more prone to side effects. The therapeutic window begins to overlap with the toxicity window and because of their sensitivity to side effects. So the importance of deprescribing is high in older adults. I think, I'm not sure if the question, maybe the question is like, when do you decide or how do you decide to deprescribe? And that is a complicated one. I often think about when someone first presents to my clinic as an opportunity, since I'm a new provider, or as we get older and we develop discussion, some patients are like, I take too many medications. Can we kind of reduce them? So sometimes I work towards their preferences, and sometimes I do intermittently will ask about, you know, can we try lower, let's find the lowest effective dose. I do have some patients who are nervous about deprescribing, so sometimes I do end up waiting until an adverse event or a side effect happens based on that person's preference or voice. So I'm trying to say that's a complicated question, but it is something that we do, and I would encourage all of us to think about.
Thank you, Dr. Wong. A couple other things came in. I want to comment, Dr. Snowden wrote in commenting on the lifespan perspective and experience of older adults as the essence of geriatrics and a worry that at times that can be lost. I wonder if that's consistent with some of your experience. I mean, you spoke about it, perhaps it's a meaningful part of your clinical work.
Absolutely, absolutely. I consider geriatric psychiatry as, you know, I think I mentioned that in that survey study about sort of holistic nature of treatments being a draw for people interested in working with dementia patients. I think of the same way. I was drawn to geriatric psychiatry because I could, I had the opportunity. It was a field that encouraged, in my mind, like a whole person type of treatment, not just the medication or the diagnosis, but also their family system, their life history, their values, their goals, their goals of care. So to me, it's sort of a draw for many of us, a sort of big picture, holistic type of care. So yes, I would confirm, or I would, yeah, I appreciate Mark highlighting that.
Now, there's one pending question. I think Dr. Unitzer, yes, was intending to rejoin.
So Lucy, I'm going to ask you directly. First of all, great presentation. Thank you so much. Fabulous overview. You know, this is an area that many of us are passionate about as a department. We've had a tremendous interest in geriatric psychiatry, you know, since the 70s, you know, predating both of us, with a lot of great mentors in the field. You know, you talked about some of the barriers, ageism clearly one of them. And then there, I think, are practical barriers. You know, it's just true that, you know, when you have a visit with an older person, everything takes longer. There is a lot more history to deal with. There is medical to deal with. You know, getting the person from the waiting room into your exam room will take 2 or 3 times as long. There might be two other people in the visit who have needs. You know, the payment for the visit is exactly the same as the payment with a middle-aged or healthy young adult person. So there are other things, you know, that are sort of more on the practical quality of life side that can be challenging. And I'm not saying that those should be excuses for people not to work with older adults, but I think they're real. And so anything we can do to think about that, it could be very helpful. Those are also sometimes the things that make working with older adults really more interesting, because it is more complex. There is a lot more lifetime history and perspective that people have, and some of us get really, you know, find that really rewarding, but it can be really challenging. My other question is, so one of the things I found that helps with that is if you can work in a team. You know, if you can work in a setting where you're bringing your expertise, but you have a colleague who can address some of the social determinants of health, and you have somebody who can do something out in the community. So the PEARLS program will not replace good geriatric psychiatry, but it can address things that you're just not going to be able to do in the office, right? And when you get to work in a setting like that, then it can be really fun and really rewarding to do this kind of work when you work with a team. So my question is, though, what is it that we can teach all those other people? You're absolutely right. Every healthcare provider, except maybe a pediatrician, will work with older adults who are struggling with cognitive impairment, with other problems. What is it that we can do to help all those people who are probably going to have the majority of encounters? Because the 53 geriatric psychiatrists we're training, we're not going to be the answer to this, right?
Oh my, this is a question I would ask you. Oh gosh, I feel like we could do all sorts of things and it's never enough. I do appreciate the Project Echo programs. I do wish there were more opportunity for me to provide consultation in some way or educate. I think it's a balance because there's so few of us and we want to provide clinical care too, right? So I have not time where I have to see patients, but I balance the time with educating others. So that's a challenge. Gosh, I'm stumped. I do like I said, I do like Project Echo. I do like the opportunity to consult, but to be able to support and train providers on that broader scale, I'm open to ideas.
Yeah, so I guess maybe what I would say is anything we can do as a field to say, what are all the ways in which we can make it real easy for somebody who's dealing with somebody in their office who's got a problem to help them out right there on the spot. You know, I think traditional CME won't do it, but you know, we probably need to think out of the box a little bit and say, what if we were able to provide a key piece of information or deprescribe or say, don't do this, you know, 4 or 5 times an hour instead of just having one more billable visit with a person, right? We might have more of an impact, and we could think about what we could do to do that. But thank you so much for this great presentation and for your work.
Oh, thank you for having me. Thank you.
Well, thank you, Dr. Wong. And that'll be, I want to make one comment. We are having grand rounds next week. We'll get that announcement out. I wanted to notify those who are still attending today. And thank you again, Dr. Wong, for presenting and walking us through this. And we'll end grand rounds there for today.